Okay, everybody, I think we'll go ahead and get started. Um, my name is Rachel Flores, and I'm the program manager for the TEXLA Telehealth Resource Center. And we want to thank you for joining today's session, today's echo session, Finding Calm in Chaos, Using Virtual Reality to Reduce Stress in the ICU. So today's presentation is presented by Dr. Joanne Romero and Dr. Olena Svetlov. Romero is the executive director for the Emergency Department, Trauma and Critical Care at Long Beach Memorial Medical Center. And Dr. Svetlov is a critical care clinical nurse specialist at UCLA Health. TEXLA Telehealth Resource Center. Let me share my screen. I'll share the first screen with y'all. Can everybody see that? Okay. So TEXLA Telehealth Resource Center is a federally funded program of the F. Murray Hall Institute for Rural and Community Health at Texas Tech University Health Sciences Center, designed to provide technical assistance and resources to new and existing telehealth programs throughout Texas and Louisiana. TEXLA collaborates with Wellhead, Louisiana, with the Louisiana Department of Health as a support representative for Louisiana, and TEXLA is a proud member of the National Consortium of Telehealth Resource Centers. And just a couple of housekeeping items. So please remember to mute yourselves and hold all questions until the end of the presentation. And if you can, please drop in the chat your name and which organization you are with. And then for the CME credits, I posted the attachment in the chat, but it will also be available on the iEcho platform, and there will be a QR code at the end of the presentation. So, and then there will be an additional survey at the end of the echo. Please remember to fill that one out as well. That just kind of tells us how we're doing with the echoes. And with that, I will let Dr. Romero begin.
Thank you, Rachel. And let me just share my screen. And please let me know if you see it. See. And I'm just gonna do the slideshow if you're okay with it. Are you able to see the slideshow?
Yes, ma'am.
All right. Very well. All right, everybody, good afternoon, and thank you for spending the time with us today. And I'm honored to walk you through a topic that sits right at the intersection of innovation, well-being, and the lived reality of critical care. And that is how virtual reality can help us find calm in the middle of chaos, based on my title here. Whether you're a physician, a nurse, a student, or new to the field, I hope you walk away today with something practical and meaningful, and that way you can carry it in your everyday life. Imagine waking up in the morning today, and from the moment you open your eyes, your brain starts making decisions, or you are even glued to your cell phones. That is also thinking about what to wear, what to eat, which route to take, how to respond to a message. And by the end of the day, we've made probably over 35,000 micro decisions. And for nurses, that number skyrockets during a single shift. No wonder our mental circuits feel overloaded even before lunch. And each shift, an ICU nurse makes about 300 decisions. These are rapid, high impact decisions, adjusting ventilators, titrating medications, responding to alarms, and even interpreting subtle changes in the patient condition. And these decisions don't just fill a checklist, they determine life or loss, recovery or setback. And imagine carrying that responsibility hour after hour. Before we talk about the VR, we need to acknowledge why this conversation matters. Remember Redonda Vaught? She was sentenced after a tragic medication error that cost a patient's life. Another one, an ER nurse who took her life because the pressure was unbearable. Lastly, an on-call nurse who fell from a parking garage after back-to-back exhausting shifts. These are just heartbreaking reminders that stress isn't abstract. It's not a vague feeling, it's something that impacts judgment, mental health, emotional stability, and sometimes life itself. We owe it to ourselves and to those we lead and to take the stress seriously. So this setting happened at Keck Medical Center of USC where I used to work and I used to be a nursing director. It's a 401 bed acute care hospital, quaternary hospital. The setting is the busy ICU, high acuity, high expectations, constant emotional weight, limited downtime. This is an environment where even 5 minutes of being quiet feels like a luxury. And yet, those few minutes can make all the difference. I just wanted to share with you their mission, and what really caught my attention always is their striving to be a trusted leader in quality healthcare that is personalized, compassionate, and innovative. Thus, I was able to afford to use virtual reality in two of their ICUs. Just wanted to give a highlight of the way that they support their caregivers. They have the thing that's called Care for the Caregiver, and their mission is to support their workforce by helping to create an environment where the staff, faculty, trainees can thrive and provide outstanding patient care by peer support, short rounds. I'm not sure if you're familiar with that, workshops, relaxation therapy, and then hopefully this one. So this practice question guided everything we did. So I asked that burning question for nurses working in the ICU, what is the impact of viewing relaxation videos using a VR headgear compared to current practice, which is nothing, on staff perceived stress over 8 weeks? This question wasn't just academic for us, it was actually personal. So I asked, could we offer something simple, accessible, and effective in a space where stress is part of everyday life? Just a little thing about this, stress and burnout is a national crisis. And one thing that I really wanted to emphasize here is that 27% of the nurses who quit have cited burnout as their main reason for leaving the profession. And we don't want any more further nurses leaving the profession. Just the reality of stress in the ICU, studies have shown that more than 60% of these nurses report symptoms of severe stress, anxiety, or depression. Why we must act now? Again, 100,000 of these nurses have burnout. The turnover is climbing fast at 17%. And of course, the cost. Did you know that replacing one nurse takes about 3 months to replace them and $50,000 as a total for all the training? What I found in the literature was encouraging. And across multiple studies, immersive virtual reality says that it can significantly reduce anxiety, burnout, and emotional exhaustion. It actually even promotes emotional recovery. It also helps clinicians feel more grounded and even after demanding situations. Basically, VR doesn't just distract the mind, it actually can restore it. Other benefits includes improved mood and resilience. And the VR that I took or I got and I utilized in this organization came from the Netherlands. And some of the studies that they did actually show that it can be utilized for patients with autism, with ADHD, and for people with depression because it can provide better coping skills. It enhances focus, professional performance. It can reduce stress symptoms and give a sense of calm. So many participants in these studies actually describe feeling mentally recharged even after just 10 minutes. But that it has to be done really consistently. So the metric, right? I used the perceived stress scale or PSS number 10. It's a well-validated instrument used across healthcare and research. It measures how unpredictable, uncontrollable, and overloaded someone feels. It's perfect for an ICU setting. Now, this is the approach that we did, or I did. ICU nurses participated voluntarily. They completed a pre-intervention stress survey, the PSS-10. They used the VR for 10 minutes with guided relaxation once a shift whenever they work. They completed a post-survey after the 8 weeks of intervention. My goal at that time was to meet staff where they were. No extra work, no complicated process. The results were sobering, even if the p-value is really minimal, but what I heard and saw was powerful. So nurses reported that they felt calmer after each session. They returned to their shift with better focus. They feel more patience with patients and families. They have clearer thinking and a sense of grounding. So now let's connect the why behind these results. The VR can reconnect the mind and the body because the VR immerses the senses in peaceful environments. Like it can show you forests, beaches, waterfalls, swimming with the dolphins, so on and so forth. It lowers the heart rate, reduces the stress hormones, and restores emotional balance. It's like taking a deep breath without ever leaving the unit. Sometimes we think to ourselves, oh, I want to go on a vacation, but only for a moment because I just want to turn off this brain. Rewiring the brain. Repeated VR use strengthens emotional regulation and mindfulness. It actually helps the brain shift out from the flight mode. VR is not an escape, it's actually a mental fitness, almost like an exercise. Recharge the spirit because VR offers a mental micro break that fits a busy workflow. It builds connection and restores empathy. And it says that a few minutes in VR can change how the rest of the shift feels. It's almost like being the captain of your ship. These are just some photos of what I utilized in the beginning. I use MetaQuest, but the thing about it is it's so complicated that I have to search for another method, which is the PicoSure, which is really a very simple thing. It's just turning it on and off. And then I provided a space to the staff members, a vacant room or a vacant, visitor's room. And sometimes they will even utilize it for when the physicians are not in their dictation room, they'll just turn off the light and use the VR there, wherever they are, but not in front of the nurses station because it's not quiet there. So just a little bit of the participants, mostly, most of them are female, and then most of them work on the day shift. Just the main key points that I'd love for you to remember, and I hope that you do. If you have the budget for it, if you have the capacity to do it, I hope that you take away these things. VR is practical and evidence-based. 10 minutes prescription is enough to make a difference. Stress regulation improves patient care. Well-being tools must be accessible for staff to be able to use them. And when clinicians feel restored, the quality of care rises. And the last slide is here because I wanted to honor and thank the team that made this evidence-based project possible. It's the 7 East and the 7 West team at CAC USC. Their openness to trying something new, their honesty, their participation brought this work to life. And just a little plug about this evidence-based project that I'm showing you. This work was actually presented at the 2024 World Nursing Congress in Prague, at the 2024 Association of Clinical Nurse Leader Symposium, or ACNL, and most recently at the AACN Los Angeles Chapter Symposium. And I'm grateful to continue sharing it with leaders and clinicians like you. Thank you very much, and I hope you found this helpful, and I hope that you will come and contact me so that we can bring this virtual reality to life in your own organization. Thank you.
Thank you, Dr. Romero. We will now hand it over to Dr. Svetlov, and so she'll take over.
Thank you. Share my screen. Uh, Trying to manage. Just one moment. Dr. Romero, what a great presentation. I know it was a great project. It takes years to build and, of course, to get the buy-in, to get the budget and get the VR to your team, for your residents, for your nurses, and making sure they are staying with you, getting the positive emotion. I really enjoy this real view of what you've done with your leadership that shows again that collaboration and working together, it really makes a huge difference in population. And seeing the pictures with Dr. Perrin right there, he's a quiet hero, but do you want to share a couple of words about him and his leadership and support?
Yeah. Oh my God. Thank you, Alina. And of course, Dr. Cobb is my mentor. And he was very supportive of this project from day one. Like I was just telling him about it. And anything and everything that we do in 7 East and 7 West is 101% supported by him. And we do what we do. It's because of also his mentorship. So thank you, Dr. Cobb, for that. And thank you, Alina, for making me speak again about him.
Yes, yes. And to be honest and transparent, Dr. Romero and I, we've practiced together at Cedar Sinai for about like 8 years together. And seeing her leadership and see what she does for the big academic systems here in Southern California at making a difference across the system, not just for nursing. So we do need leaders like you, and I'm really happy with your promotion to Long Beach, another academic center, and can't wait to see what else you can do and more. With that, this is Alina Svetlov. I'm a clinical nurse specialist, doctor prepared. I am a nurse. I have a doctoral degree, but I am a nurse, and I'm very proud that I have a chance to practice with my nurses, with my doctors, with my residents and future doctors, and happy to share the role of telemedicine today, a little bit with the backward, what was there a little bit before COVID, and why we're changing, and what are we doing, and what would be our future. Trying to navigate the slides, and I hope I can manage that. Looks like it's working again. Dr. Romero, thank you. And I would like to start with a huge thank you and appreciation to Society of Critical Medicine. And I'm wearing my jacket every day wherever I go. This is the only organization, professional organization in the world that looking at the system together for the benefit of the patient. So the society itself dedicated focus is excellency in patient care through the team approach. So this is the only organization that you kind of like have a voice to say. You see the doctor who is leading the practice, looking at the research, bring back to the team. You have a physician, therapist coming in, physician assistant coming in, nurse practitioner coming in, CNSs. We're all in together with the help of our pharmacists and trying to tailor the best that we can deliver to our patients. So thank you so much for inviting me today and share a little bit about telemedicine that we have. Another picture that you have on your slide, it's a beautiful view. It's it's a beautiful place where I go. It's actually a kind of a sacred place for the past Indians that used to live there. It's El Matador Beach. And if you ever get to go to Southern California next to Malibu, it's a beautiful place called El Matador. And you'll be able to see the elephant that actually drinking the ocean water. And the sunset and the sunrise, you can see the sun coming through this underneath. It's a beautiful place. So hopefully next time we can host a session here live. And Dr. Santos, that's going to be on the bucket list to come and visit, right, Rachel? We'll go there. Full disclosure, I would like to have more disclosures as any speaker that I would like, but I'm honored that I've been invited to practice just 3 months ago at UCLA Health as a subject matter expert in all the cardiac issues here in UCLA Health. I'm overseeing critical care with cardiothoracic patients together with the CICU. So that's a passion of mine, and we see the combination of these beautiful minds working together. Also, I'm proud to share that we just recently opened up a nonprofit organization that called Svetlo USA. And I'm also open up the consulting company where a lot of people reaching out and asking for the wellness advice as a dual certified clinical nurse specialist and a nurse practitioner, adult general nurse practitioner. I'm able to provide this consultation for free. So that's my disclosures. Learning objectives for today is basically one objective. We want to see how we can have telemedicine technology today in our practice and making sure we're enhancing the practice for our patients and for ourselves. And I'm going to give you an example how I use a telemedicine in my practice daily for the past 3 years now, daily and on a global perspective as well. Because I'm in California, I'm actually in order to get the CEs, I have to disclose my biases. So my biases says I am from Ukraine, born and raised in Soviet Union, but it was in territory of Ukraine, sovereign country, and I have to disclose that some of the information that I'm sharing with you today will be a little bit of Ukraine. I would like us to take a moment and look at the slide. Our life is full of emotions, full of interactions with each other. And sometimes those interactions are not that great. When we're joining the organization, we're joining the ocean of their own waves of caring for patients, policies, practices, systems that are in place that we really don't know. So what we're trying to do is anytime we're coming and joining an organization, we're trying to be that surfer that master the craft, that we can sail through or surf through the ways of navigation for the system for the better wellness of the patient. I really like that slide because you're looking at the waves and you look like sometimes we're getting our trauma patient and everything in the chaos, but we are mastering our craft. We actually know how to manage it. And the key component after this turmoil of emotions and drama and safety and sometimes not comfortable conversation, how do we take care of ourselves? Because as a caregiver, we master to care for others. We spend years in school, medicine, nursing, pharmacist, physical therapist. Today, we're required to have a doctoral degree in our practice. It takes decades to get in our practice. But how we learn how to care for ourselves. That the art is not in any curriculum that I'm aware of. If you have any information about it, please let us know. But as of today, there is no information how we need to take care of ourselves. So hopefully by the end of this presentation, we get some little tips how to do that. What are we having today? From national healthcare and a global perspective. From national healthcare, I would like us to go back to the year of 2020. So just maybe you remember that moment. If you have some information in the chat, just put it in the chat where you were when the COVID news broke up to you. And Rachel, I will need your help, to look at the chat and see. Well, I was at Cedars-Sinai, and I was at work in my SICU, surgical ICU. Any other? Okay, let's see, chat. Where you guys been? Okay, we have Fonyu. Dr. Santos was in Hawassa in Ethiopia. Baltimore, yeah. Sharon, yeah. Dr. Williams on the burn unit. Yeah, Dr. Romero at Cedars, exactly. So on the Western Coast, this news came very abrupt. We're not sure what to do. We're not really believing what's happening, right? Progressive care in the hospital, Hanover, Pennsylvania. Yeah, so we're across the world. So this January 2020, I was traveling back from Ukraine for my volunteer mission that I was doing, and I've noticed that people are wearing masks in Germany. I was like, why people are wearing masks? And I didn't really pay attention, but it was kind of interesting. Like a lot of people were wearing masks. I'm like, oh, what's up with that? So coming in back to work, we're at work and we hear news that Kobe got crashed, right? In March, early March, we hearing that he crashed here in Calabasas. That I never forget that day. It was really a lot of fog, and I live in Calabasas in California, and I hear a sudden boom. I was like, what was that? That morning, I couldn't even see my dog on a leash. That fog was so thick, and it was so quiet, and all of a sudden, I get that explosion, a noise, and a lot of alarms went off. So that Los Angeles Times came out, and they had a news about Kobe death. Next to that notice, we have a publication about COVID coming in from Dr. Fauci. We didn't really pay attention to that because, as I mentioned earlier, we're in the ocean of emotions and we really see what is given to us by the media. Health was not that much in the media, never does. But slowly, this wave of information start coming in through our personal relations, if through our WhatsApp, Vibe, we're getting emails, and now our colleagues across the world saying, hey, Italy is really broken down. So we start using the devices or the apps or the platform that we can talk to our friends, our colleagues, our peers across the world, and trying to pick up the knowledge and see where we are, what we can do. I recall March 5th, 2020. It was Friday. And we actually, Dr. Romero, you were there, you were a leader at that time on that particular unit. And her unit, just in the movement of a second, her nurses were told, today you're taking care of a COVID patient. And we became a mecca of Southern California at Cedars-Sinai, getting all the patients to 7 Saperstein, which is our COVID ICU. So do you think Dr. Romero went home? No. Do you think I went home? No. It was the end of it's Friday night. So we stayed with our nurses. And not only that, we stayed with our residents because they had to huddle immediate decision-making capacity, what we're going to do with these patients, how we're going to treat it. There were no protocols. Where we're reaching out and using our telemedicine at that time, reaching out to our colleagues, Wuhan in China, in Italy. I was reaching out to Ukraine and trying to see what they're doing. So fast forward today, political arena, we have strong leaders across, we have a lot of political crisis going on. And then they're in charge also of a health industry of these big countries, United States, European Union, Russia Federation. We have a lot of things going in Iran. And because of a conflict, we have a lot of mass destruction going on. We just finished the conflict in Gaza. And how you can provide care in the hospital that just been destroyed. In Ukraine, how can you provide care where schools, hospitals, people were destroyed? So from global perspective, we see more and more use of telemedicine devices. And yes, we're giving, but at the same time, we're causing injury to ourselves. Yes, we're caring, but do we have a mechanism in place to address this moral injury that's happening collaboratively across the world, not just in the United States? So Wendy Dean, we probably heard about her. She committed suicide at that time. She really brought up an alert to every single provider in the world that we need to do something to make sure we're safe. We need to have a safety mechanism for our wellness. And I'm really grateful that Dr. Romero showed to us that in other devices that we can have, it's a VR. Maybe you can advocate and have it there, that have that moment to yourself, have that moment in between that burn patient that Dr. Wilson taking care of, to go in and just withdraw and be in a little bit of a safer mind, a safer capacity. This is a day hour in the CICU. We're coming in with a trauma patient to the left corner of your screen. You see the Alaris pumps, they're alarming. Lots of drips, lots of monitoring going on. Night shift, same thing, alarms going on in our residents. That's why the terminology of residents came in, because they live in the hospital, basically. Hours of hours intense work and making a very life crucial decisions for patients. But do we have the air in this alarm and really vulnerable environment for us? What do we do in a government perspective? COVID really opened up a lot of opportunities. We created and discovered Zoom platforms, team platforms, virtual reality. But before, if we're doing a telemedicine visit, their terminology was not that fancy to use. More than that, we're not really that much of reimbursement were at that time. So thanks to COVID, we have a change in delivery of our care. So in response to COVID-19, the telehealth was actually adopted and Medicaid is providing reimbursement. So what does that mean? For our older patient population, we can go ahead and provide the visits that they cannot really come to your office, but in certain parameters, you'll be able to follow up. If your patient's discharged, you'll be able to follow up. Also, boom of technology coming in, right? And it's also getting reimbursed by the systems. You have to have a computer. Now, all the computers in the hospitals, immediately now we have cameras, and we're able to having our conversation today using the camera, using the platforms. The payments rates were adjusted. Fee for service, that's been adjusted as well. Rate and cost of sharing for nurse practitioners independently, for CNSs practicing, for the doctors, that's already have developed, evolved within the past 5 years. And what we're benefiting, basically we're getting more knowledge and more experience because we're easy to jump on a Zoom call and we're talking with people from Ethiopia and learning up what are we doing over there and how we can exchange our information, getting better in our practice. So it's really like CMS really adopted and provided good strategies and really happy with that. More than that, we have our websites that our government provided to us, and actually anybody can go there, and our patients can go there and says, "Hey, we have a telemedicine. Oh, what is that?" So they can jump in the language of a fifth grader. They'll be able to read and learn. So what telemedicine does to us. Basically, it's in a comfort zone because the patients can be at home with their loved one, less delirium because they're not changing the environment, they're staying there, and they can ask questions that sometimes they forget when they're waiting on the line to see the patient or when they're getting admitted. And so in some areas I practice in Kaiser, California, we are overseeing 3 to 4 hospitals overnight. Los Angeles Medical Center overseen at night with the telemedicine, so many ICUs. If any changes are happening, our neurologist coming in through the IVA, through the telemedicine device, we're connecting, the nurse connects, and a patient can be seen by the doctors. It's amazing. So we have a lot of benefits, but what we as providers and nurses can do, nurses can actually just in time notify the physician of slightly changes. If any aphasias notice, let me double check with that. Let me connect with the doctor and see if they can do the assessment and give you the orders that can actually justify the plan of care that you're going to be developing. So for acute medical centers, big change. We can have a surgeon, we can see a trauma surgeon seeing geriatric patients who are at risk for falls. You can see, you expand the way of how our residents can see and learn assessment skills using virtual tools. This is another empowering thing because going forward, once they graduate, they're not only learning the hands-on assessment, but they're learning also virtually how you those subtle signs they can see and assess and pick it up, reading those vital signs, looking at the labs, but at the same time correlating this with what I see on the screen of that patient. For the tertiary center is a big deal as well because now we have the system that incorporated the payments, incorporated the academic center, teaching supplies, and can advocate to have more residents being able to come and join. also good from the nursing providers because they can talk through together with the teams. And doctor might be seen on one hospital, but the nurse practitioner could be on the other side and be able to connect, says, hey, what do you mean to follow up with this patient or whatnot? So connecting the dots and the biggest systems and big environment, right? So for rural areas, some data for you. So in nearly 80% of regions designated as medically undeserved, meaning a significant disparity exists in accessing healthcare. So with the telemedicine, we'll be able to see those patients and provide the care as needed. In rural areas, doctors, nurse practitioners, CNSs can see the patients virtually and can provide care as needed, just in time. Our urgent center can actually incorporate using the telemedicine as well, because urgently, they have a cow, the cow, have run over somebody. Okay, what's going on? Okay, you can show how to stabilize the spine right there virtually before the paramedics arrive, because it might take an hour to get there. So multiple opportunities. Specialty, our dermatologist, just a big, simple example, much better, because skin, it seems like for a rural area of people who doesn't have that much of education that as we have, right? They can really come and say, oh, it's just, little mole, that's okay. Everybody has a mole, but we'll be able to identify it right away. So isn't it fantastic? So moving on. I shared with you that I do a lot of work with Ukraine. So every year I go and do some missionary work. And last summer, I was able to provide the Stop the Bleed training virtually. But when I was there in person, was explaining how to use a tourniquet. And obviously, because of different logistics and different suppliers, they're using different types of tourniquet at that time. So there were no like Cat 3 modified. They kind of like have a modified version. So bringing them a large amount, I think I brought like 250 kits of a Stop the Bleed, and they were going over and looking at the tourniquet that's supposed to stop the bleed. And they asked me, Alina, can you just explain us what it is and how to apply it correctly? So I provide this training for only a small group of people, but using the Viber technology, which is another platform of communication with the video calls, we're able to provide it virtual assistance, how to provide the application to a bigger group of people. And this is actually local police of a city of Zhytomyr, where I'm from. This is me providing real care in a rural hospital there. So the patients is real patients. So she was walking across, I don't know how to translate it, across the field, and she stepped on the nail. So the nail went through the entire foot. So practices protocol in Ukraine in that particular area is to put some kind of ointment and wrap around everything with a plastic bag, and everything should be in plastic. And they are giving once in 24 hours IV antibiotics with a reusable needle. So you have a bottle that they mix medication, put that bottle, have a rubber runs to in, and they have a needle that they reuse it. So you attach it, you do the infusion over 30 minutes, you take the needle out and put it back into the bottle, and this is how it stays for the course of treatment. Everything else like gauze, gloves, pads, the patient is required to buy and bring to the rural hospital. Doctor is not on site. Doctor is somewhere in the fields, seeing other patients, going from houses to houses. So the whole hospital doesn't have a doctor. Luckily, we have WhatsApp and we have a video correspondence. I was able to connect with the doctor, humbly introduce myself and ask what's his protocols. And I asked permission via WhatsApp if I can have this conversation with him and share our protocols that we have here in the United States in caring for the ones with such diagnosis. And I humbly asked him if it's okay to share the advice, because I don't have any authority to treat. He's an authority to treat. And I'm really grateful that United States provide me with such a training communication skills training in medicine and practicing as a clinical nurse specialist and adult general nurse practitioner. And I was able to communicate, and the protocol that we have, that the doctor actually listened and open up to take off the plastic and keep the air going and have the protocols with the treatments and changing the dressings daily. That's a win. But that was able to do again without telemedicine. That's thanks to that. Another thing with our wounded on zero, line zero, we call it like line zero, that's a combat state. So something that through my nonprofit organization, we're able to raise funds and bring this carrier that the soldiers can bring the wounded out of the field and provide the first aid. So I was able to do like this. Alexander was able through Viber communicate and explain to them how to stabilize the spine, how to navigate so the patient, and how to use it safely during combat and how to take this out. And it's really a privilege to learn a lot here in the United States, and now with the power of telemedicine to help globally in the area of crisis, what me as a clinical nurse specialist can do. So I hope you learn from the session today that yes, it's great to be a provider. Yes, it's great to care for our future doctors and future nurses. But ultimately, we have to have a question to ourselves. What brings my heart? What makes my heart full? What did I do to myself today? Because of so many meetings, so many interactions, so much I was giving and giving. But what did I do? Something good for myself. Did I have a little bit of a cup of coffee? Do I hydrate myself? I put a sticker on mine that I bring the light, and then kind of like looking at me throughout the day from here at the table. But what did you do to yourself? And maybe you can put it in the chat. What's maybe something that you promised to do to yourself so you can feel better? With that, I will conclude and open up for the questions. Thank you so much.
Thank you so much, Alina. So Dr. Romero, she said she used the VR for 10 minutes. And I do have a question as far as the content that's displayed on the VR, is it are they like games or
No. It's not gaming. So that's why it's such a special equipment. So when you turn it on, and in fact, I have it here to prove to you that I use it. But I'm not in any way, form, or shape being paid by the organization. But when you turn it on, it actually allows you to pick and choose which scenery you're going to be at. So whether you want to be at the beach, it includes 360 immersion. So when you go up, look up and down, left, right, whatever, and then you are fully immersed in it, including the audio, it's almost like you are there. And since this was made in the Netherlands, particularly in Amsterdam, there's a lot of great things that you can see there. Like you actually can feel that you're immersed. Like if you have not gone to Alaska or something like that, like, you can actually be immersed in it as if you are like dog sledding. Or if you want to be swimming with the dolphins and that's your dream, you can actually be on it and see the dolphins and hear them. Or if you want to be in the fields, like if you've never been in Africa and you want to see the elephants moving about there, like in the field or something, you can actually almost feel that they're almost in front of you. So it takes you away from thinking because that's all you have, right? Instead of meditation, because meditation is a technique, it's a skill that you have to have. This one, you don't even have to think of anything, but you're just right in it, right? So that's why a lot of patients, when you look at the studies, I think, each and every one of us have some sort of ADHD because we multitask all the time, right? Like you're doing something and then like, oh, okay, let me do this. And then you forget that you're doing something else and then you switch to another thing. And then I don't know about you, but I drive really long hours right now. And sometimes because I'm thinking of what I will do, like for the next how many hours, when I arrive at the parking lot, I tell myself, how did I get here? Right? Like, I mean, that's really dangerous because you're just, okay, I'm driving a Tesla, but I'm not doing the drive, the self-drive, the fully self-drive. No, 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 I can't do that. But what I'm saying is that because your brain is constantly thinking, right? I arrived at the parking lot not knowing how I got there. And that's really dangerous. So that is why I'm like, let me just, go and immerse myself into the VR. But that VR is something like based on what Olina had said, something that you owe to yourself, right? 10 minutes a day of you immersing in it and turning off your brain will be helpful so that you can think better, you can concentrate better. And you owe it to yourself. You owe it to your staff. Like if you're a leader, if you're a physician, and you have residents that are just up here with the things, constant thinking, you owe it to them. Our organization owe it to our staff.
By the way, Dr. Romero, that is an excellent presentation, and as well as Dr. Svetlov. So, congratulations and thank you. Spasibo, Dr. Svetlov. Um, could you potentially, Dr. Romero, put in, your contact information so we could potentially contact you? I am personally intrigued, about this, and I think, $400 for the gear, and I think we could share that to all the staff though, right? And so I think, $400 and 1,000 subscription, you said unlimited use, so that will be excellent. And you could potentially pick which one, scenery or, depending on
Yes.
on what you want. How many choices are there, that
60.
all
So
right.
they actually did the sceneries in the Netherlands. Like if you've never been there, you will be immersed into it, like Iceland, like the Gakafoss, whatever falls or something. And
Mm-hmm.
right, I forgot what Reykjavik,
Yeah, Reykjavik
places
is in
like
the
that.
Iceland, yeah.
Yeah, they also had it done in Hawaii, like the beach
The
there or
beach.
something like that. So there's about I think right now they're upgrading, they constantly upgrade the software. So I think it's now it's actually probably like close to 70 because there's
Mhm.
also a way that you can play with, I mean, not play, but look at the cats, the dogs, if you like that, just to remove yourself from thinking about anything but that.
Is there any particular, study done, whether you do it 15 minutes or 10 minutes or,
Yes.
and what
Yes.
particular scenery you will be
Mhm.
looking into? Is there a particular study which one is better than the others?
Yes, and I do have the references, in the presentation. I'm not sure, Rachel, if we're able to show that, but in some of the studies, 3 minutes is enough. In
Hmm?
some studies, five. So it can vary, 3, 5, 10. What I chose is 10 minutes, and that's really a lot. I mean, some of the respondents actually said they fell asleep, and that's good. It means that you really like they didn't realize that they already like were asleep, like for I don't know how many minutes.
But by the way, for the nurses though, I knew the supervisor doesn't like that, when you fell asleep or something like that, right?
Well, yeah, sleeping and like just closing your eyes are two different things, right?
Okay.
But
All
if
right.
it's only for 5, 10 minutes, I think that event, I mean, in UCLA, when I was working there, we were allowed 15 minutes to do like a nap, right? Like
Mm,
like when you nap, not sleep, when you nap, it's called the energizer nap.
power nap.
When you come out of that nap, you can concentrate better. I don't know if you've tried that for yourself, but try napping, just closing your eyes and not thinking of anything. And when you come out of that, you can concentrate better and you feel better. So in some of these studies, one of the things that they said that's helpful is to actually see the greeneries. Like when you go out there, when you walk, let's say during lunchtime or something, that helps. But for our ICU nurses, they don't have time to go out and go and immerse in greeneries. So that's why we want to make sure that we bring it to them, not them going. So yeah, you can look at one particular study is the one that was done by Beverly, and these are doctors, these are nursing DNPs. So you can take a look at that. And what they did was they studied it during the COVID pandemic, when everyone was just like, I'm so stressed out and burnout, I want to quit. So they tried and tested it, among the frontline healthcare workers during the COVID pandemic.
I do remember actually when I was in Toronto that the nurses are actually encouraged to power nap. There are a rota of schedule, when you could do power nap, and I think that's helpful. I know there's some culture, here in the United States that you get written up if you do that, even though you're just closing your eyes in the nurses station. But I think this is better way of as you mentioned, reducing burnout, improving productivity actually, and making us, safer with our patients and promoting wellness. So I actually I would like to try, this VR, and you said that this is available to trial and open to hospital for testing for free. So I think we
Exactly.
had to subscribe that. Thank you very much again, Dr. Romero and
Thank,
Dr. Spedlov.
thank you. Thank you for those questions.
Thank you, everybody. Yes, so I have the slide with our contact information, if anybody wants to take a screenshot of that.
And Rachel, I'd just like to remind that this, webinar is recorded and will be available to view, and we could give you the link so you could actually share that to your nursing managers and leaders so they could potentially use this in their respective units or institutions. Probably in North Carolina, Dr. Williams.
Yes, and it will be available on our YouTube channel as well. So and
That's
then
great. I just want to add one little thing. Well, a huge appreciation for you, for the team, for this amazing project that allow us to share our knowledge and expertise. And Dr. Romero, thank you again. I really admire your practice. So anything that I have an opportunity to share, thank you. Please come with me and share your knowledge. They're amazing. And I also would like to let everybody know that on a national level, there's a huge movement going on. It calls Healthy Work Environment, that the American Association of Critical Care Nurses working strongly in collaboration with American Association of Nurse Leaders Association. And yes, it was a culture, I would say, 2018, 2019, to write up a nurse who would like to sleep in the break room and using the blanket. And no longer is such a thing. COVID really opened up the eyes and levels and changes leadership styles. A lot of leaders going through the training to understand what their healthy work environment means and what does it mean to be a leader. We see the shift from the use of manager. We seen the language used to the leadership. And now for any organization that you would like apply to become a magnet, you actually really need to show the data that you do something as wellness across the systems, not just for nurses, but also has to be across the system with the doctors and the residents and their wellness as well, pharmacists, the whole team. And data is quantified, and you have to meet certain parameters. Like for healthy work environment survey, you have to be in a range from 4 and higher. The higher is 5. So if you're below than 4, then we got to work something in there. And it's detailed. And in order to get like a beacon, it's highest level of appreciation of everything what is done, excellency on the units, that you have to really meet those marks. So that's a huge change going on. Good things came out from COVID, not only telemedicine, but the changes in leadership on all the spectrum. So thank you.
Thank you, everybody, for today's presentation. It was very interesting, Dr. Romero and Dr. Svetlov. And again, thank you to SCCM Surgery Section for partnering with us for this presentation. And again, don't forget to fill out the CME packet. So just follow all the steps, and then there will be an additional evaluation survey after this, specifically for the echo. So thank you, everybody, for joining us today.
Yeah, thank you. And one last thing, probably Dr. Svetlov and Dr. Romero, we could probably propose this in SCCM Congress to do a VR for participants. I think it will be a great idea, and why not try it for our patients as well? I'm thinking, this is my hypothesis that could potentially decrease, opioid use if you are in virtual immersion. So yeah, something to think about. Thank you
Thank
again,
you,
everyone.
everybody. Y'all have a good day.
Yeah, bye-bye.